Hey folks, I'm sitting here in my hotel room in Saigon and on my way to the APEC meeting, giving a couple of talks down there. But I figured a question that had come up here online that I thought was important and pertinent, and it's one I made a video on before about one visit versus two visit treatment on cases. And it was also a subject of my previous video in Portugal, in which I did the case that I did without patency in a single visit. And a lot of you guys asked, well, you know, did you do it in one visit or multiple visits and so on with calcium hydroxide? Now, personally, in my practice, I do the vast majority of cases in a single visit, whether they're treatments, retreatments, or necrotic or vital, any of those cases. Now, I would like to talk to you about that in this video, in which I can try to explain what are the biological requirements for doing cases in a single visit, when should you do it and when should you not do it, and then we can at least have a little sense of, at least from my perspective, a consensus of what I do in my clinical practice that may potentially apply to you as well. Let's first understand that while the use of calcium hydroxide in some of the studies has been shown to be better, and therefore doing things in two visits has been shown to be better in some of the European studies, there are also many other studies that were done in the 90s and in the 80s that showed that a single visit treatment of the cases did not really affect either the outcome nor the postoperative pain. In fact, there were some studies that showed that single visit treatment had a lower incidence of pain, and that many times the incidence of pain increased if the cases were done as multiple visits. Now, from a patient's perspective, I think we can all agree that all patients would prefer to have the cases done in a single visit. However, we all know that patients also want to have the predictability of outcome, so that doing cases in a single visit, if the outcome is going to be different or poorer, is not going to be something that they are going to be interested in doing. So let's quickly analyze whether the outcome is the same or not. And that really takes us to the whole concept of doing single visit versus multiple visits treatment. And that is that the essence of achieving great outcomes is independent of the number of visits it takes to complete the treatment. The essence is complete eradication of the bacteria, biofilm, and any inflammatory byproducts, as well as total volume of tissue in the canal. And whether that can be done all in a single visit or it requires multiple visits is really the principle here. So it has to do with a combination of the ability to do all of those things in a single visit from a perspective of having adequate time, and then the ability to doing all of those things that I just mentioned from the perspective of having enough clinical skills and expertise. So the more efficient and more robust your protocols are for your cleaning, shaping, and disinfection, and the better you kind of work with your assistant to achieve all of those, you might be able, from a clinical perspective, be able to achieve all of those objectives of root canal therapy, being first and foremost finding all of the canals and then achieving length in all of them, and then getting to an adequate apical preparation with adequate irrigation and disinfection so that you can obturate with adequate time without feeling rushed. That's really the essence. If that's what you're trying to do and you're able to achieve that in a single visit, then by all means, there really are no biological requirements for doing these cases in multiple visits. Do it in one visit. But if you can't achieve all of those standards and objectives in the amount of time that you have for doing the root canal procedure, and that could be due to multiple reasons. Number one, the patients might be in for an emergency pulpectomy, that you may have allocated a certain amount of time, but when you go inside the tooth, you find that there are additional canals that you find out, or that the complexity of the canals is more, or that the patient is either anxious, nervous, or is unable to stay open long enough due to various kinds of TMJ and TMD problems. Those are all cases that really should be done in 2 or even more visits. You may have to cut them down in multiple visits in order to achieve those objectives. Now, one thing that becomes very handy in terms of knowing the cases that you're dealing with. Now, you may not know if the patients have the ability to stay open long enough, but having a CBCT preoperatively where you can find out about the number of canals that you have, their locations, and their, the complexity of the root canal, having pre-planned the tooth adequately using your CBCT will go a long way in terms of you being able to then allocate adequate time, treatment time for that given patient so that you can achieve things in a single visit. Giving a stock treatment time for every patient is going to run into these kinds of problems in which you may be surprised by the complexity of the canal, and then you will have to schedule the case in multiple visits. So having pre-planning by looking at this, having a CBCT that you can look at ahead of time, and then allocating adequate time for that given patient based on that pre-treatment planning and radiographic analysis, and then perhaps during that consultation visit, having a question, checking and seeing how far the patient can open, how much your access is going to be to the area, and how long can they persist and how long can they stay open in that position is going to go a long way in terms of you treatment planning, and adequate allocation of time for the treatment of that tooth will go a long way in terms of you being able to do the case in a single visit. But if you just treatment plan patients the same way and you allocate, I don't know, hour and a half for a molar or hour for a molar, and then different times for anterior or premolar tooth, that's not adequate treatment planning for knowing whether you're going to be able to do the case in a single visit or not. So this is one of those cases in which you have to be, in fact, intentional in your treatment planning and customize the time allocated for a given tooth's root canal based on a number of factors, given the patient, given the anatomy, and given the radiographic requirements of the tooth, and your own personal skills in being able to achieve all of that in a given time. I do not recommend scheduling patients for longer than an hour and a half anyway, because at some point you're going to reach a point of diminishing returns in which your patient's TMD symptoms post-operatively could kick in due to staying open for too long and having all kinds of problems by being open too long. So if you have enough skills in the earlier part of your career, you may have to do more cases in multiple visits. But as you end up getting enough skills and you are able to find an assistant that can help you achieve that kind of synergy so that you can achieve and implement your goals of cleaning, access, cleaning and shaping, and obturation and adequate irrigation within the time frame that is in your patient's ability to stay open, then you will be able to do more and more cases in a single visit. So as I mentioned, with time, you will be able to do more and more cases in a single visit. But let's talk quickly about what are those situations in which I would not then be doing my cases in a single visit. And those are fairly limited to a couple of specific situations. The first one is one in which I don't have adequate time to achieve my main objective. So remember, the whole question of whether doing cases in a single visit or a multiple visit is really driven by the objectives of root canal therapy, which is the ability to find all the canals, get down all of them, clean and shape the apical area adequately to a large enough size, and have adequate irrigation inside the canal long enough that it can digest the tissues that are in the canal and kill the biofilm and remove it adequately. So if I don't have enough time to achieve that, or if the patient's unable to stay open long enough for me to achieve all of that in a single visit, that will require multiple visits. So I may go to a second visit. And of course, in every situation in which you do require to have a second visit, the key point here is to make sure that you dress inside the root canal with an antimicrobial agent so that you don't end up having regrowth of any biofilm and bacteria inside the root canal. Lastly, the only other reason in which I would not be doing the case in a single visit is if I have drainage. So if you want any biological limitations for doing a case in a single visit or not, that is not a function of time really and objectives, is the fact that the canal is not dry. So if I have consistent drainage from the apex, whether it's uncontrolled bleeding or if it is due to pus or other kind of drainage inside the root canal, those are actually the contraindications for filling the case in a single visit. So that's very important to keep in mind as well, because I wanted to say that I do the vast majority of cases in my clinic, being 90-95% a single visit, but the situations in which I am not able to achieve my objectives in the time period, or if I have drainage at the apex, are those cases in which I would not fill the case in that same visit. I may place in a calcium hydroxide based material such as BC Temp or regular calcium hydroxide, and then allow for that to kick in, and over time, over about a week later, 1 or 2 weeks later, when the patient comes back, then I will be able to fill the tooth and get things done. Now, I've heard jokingly in some patients, in some of the colleagues, that sometimes they may not fill the case if they have questions about the prognosis of the tooth and so on and so forth. As far as I'm concerned, after you've done the cleaning and shaping and disinfection, filling will take very little time, and therefore it might as well fill the case so that it would be completed. And if somehow you don't have any confidence about the success of the case down the line, you can always either reimburse the patient or do anything else that you would have done with the calcium hydroxide therapy. Because in my opinion, especially if you're using very efficient obturation techniques, the hydraulic condensation, for example, compared to calcium hydroxide placement, there's very little difference, and you should be able to achieve that either way very efficiently. So I might as well finish the case so that then you will have a far better idea of whether the case is successful or not. And also, you don't have to bring the patient back only for obturation. Remember, patients don't want to be anesthetized twice for the same thing, or have to come back twice for the same thing. And also keep in mind, I've heard some people say that during the obturation visit, they don't anesthetize the patient, which in my opinion is a mistake, because you should always have the patient anesthetized for a pain-free experience. And we can talk about that perhaps in another video as to why that is the case. All right, guys, didn't want to make a long video on this one. So the point that I wanted to get across here, based on the question that came up online, is that doing cases in a single visit requires, first and foremost, strict adherence and meticulous adherence to the overall objectives of root canal therapy within the time that you have in a single visit, considering the patient's limitations of staying open and tolerating the procedure during that time. If the patient is unable to do that, or if you don't have the skills to achieve all of those objectives adequately within that time period, then it's important for you to take as many visits as it takes to get things done. This is a process of getting and improving, and that's probably why we call it practice, because you're supposed to get better and better with time, and as you do more cases, you will feel more comfortable. Anyway, guys, that's it for now. For Real Dendo, I'm Ali Nasseh, and until next video, let's save some tea.